Imagine getting on a plane to head to an EMS CQI conference and hearing the pilot say, according to the pre-flight checklist, we've got a full tank of gas and perfect tire pressure, unless somebody fat-fingered the data again. Would you feel safe flying at 35,000 feet with unruly passengers and a crying kid based on that sloppy documentation? Of course not. So why is EMS okay making life and death decisions based on misentered NEMSIS data on a patient care report? Hello, everyone. I am Kevin Kelly. He's the sensei of EMS CQI, Paul Gerard. We are Gerard & Associates, your national EMS CQI consulting firm. You're listening to the G&A Way EMS CQI podcast, available on Podbean, Apple Podcast, YouTube, and everywhere you get your shows. Please hit those subscribe buttons. We're grateful that you tuned in today. Paul, how are you?
I'm well, Kevin. How are you?
I am all right, thank you. This is a big topic.
Yeah, I like that we say this at the beginning of every topic because it's our topic on our mind, something big we want to talk about. But this one legitimately is a big topic because it's a topic that everybody has problems with, whether they realize it or not.
So let's jump right into it. What is NEMSIS, and why should EMS CQI leaders care about NEMSIS data? Paul, what exactly is NEMSIS?
So NEMSIS is the National EMS Information System, and it was created about 20 years ago to standardize data collection from EMS agencies so that at the state and federal levels, decision makers can make determinations on policy, protocol, how to operate ambulance services and whatnot. A variety of different EMS-related decisions could be made based off of the data collected through the NEMSIS system.
So in theory, this is a great tool for improving pre-hospital patient care and EMS provider accountability?
Yeah, absolutely. It's a great way to see what everybody's doing on a national level and to see how there are differences in different parts of the country and whatnot. We certainly need a national data repository, no doubt about it. So it's certainly an important aspect of EMS going forward.
Speaking of data and statistics, was it lies, damn lies, and statistics? Is that the
Yeah.
is that the old saying?
Right.
So I once saw a headline saying data suggests that homicide victims never speak to the police. Yeah. That's what we're up against.
Yep.
So when the numbers lie, you got a great case regarding intubation and intubation success rates. You wrote a great case study that really drives this home. The intubation success rate and what looked like a protocol failure that would have created liability and risk for the EMS providers. Mm-hmm. Walk us through what happened.
Yeah. So I kind of want to start by saying that the problem everyone has, every EMS agency in this country has, is that they're reliant on their NEMSIS data coming out of their ePCR programs primarily, and that data is grossly inaccurate. It's just not accurate for a variety of reasons. And at the local level, managers and policymakers are trying to make positive change to EMS based off of, in my opinion, significantly faulty data. And as an example, the case that you brought up a few years back, the state, when they would go in every couple of years to do the agency's inspection to re-credential them for another 2 years, they go in and they check, count Band-Aids on the truck and all that stuff that OEMS does in order to certify your ambulance services in compliance with everything. And one of the things they were doing a few years back is they were going to agencies and saying, give us a report off of your ePCR program showing your intubation success rates. We want to know if your providers are successfully intubating patients. And for one agency that we're working with, they saw that there was about a 60% first pass success rate. And that indicated that there's a 40% missed first attempt intubation success rate. And, we said, hey, that can't be. That just doesn't sound right. That doesn't square with our data. So we pulled the data. We spoke to the medical director. Now, for cardiac arrests, the medical director reviews every single cardiac arrest. And he said to me, I can't believe that our intubation rate is that bad because I review every cardiac arrest and airway management's not a problem. Mm-hmm. So we pulled the data, and what it turned out to be, now there's a couple of points here that are important. If you're relying on your PCR data for your CQI efforts. One was that the sample size was really small. This agency wasn't very large, and they only did about 10 intubations a year.
All right.
So small sample size, right? And that can always be skewed. The second was that the 40% error rate was a combination of data entry errors and various interpretations of what people thought the PCR program was asking of them to enter their data that turned out not to be an intubation error rate issue. So on one case, the provider simply mislabeled the call as cardiac arrest. They actually had a shortness of breath patient. They were thinking of intubating the patient. They got all their equipment out. They made this half-hearted look in the back of their airway to see how bad of a job this was going to be, and they chickened out and said, nah, he's still too conscious. He's not going to take a tube. It wasn't a cardiac arrest intubation scenario. It was an intubation attempt scenario. I should rephrase that. It wasn't actually an attempt. It was simply a preparation thing. But they documented in their skills section that they made an attempt because they prepared to make an attempt. So just wrong. Shouldn't count, but it did. In other cases, the providers made a first attempt. They found it to be a difficult intubation. They backed out. They used their rescue device, an LMA in this case, and they successfully put an LMA, and they did a great job ventilating the patient based on having a secondary airway. And so the medical director reviewed it and said, this case is appropriate. That's what you're supposed to do if you have a problem.
Yeah.
So those were counted as missed attempts. And, in fact, I guess you could say they weren't able to pass the tube the first time, but the airway management was tremendous. So OEMS was going to cite the agency for having bad airway skills and therefore need to go through a sim lab, identify your people who can't intubate and all this sort of stuff when they actually did a really good job on airway management. And that airway management met with OEMS regulation in terms of how they're supposed to respond if they have a difficulty at a first pass. So is that really an intubation problem that they need to, send the whole department through a sim lab for? Probably not. But understanding your data first before you make those decisions is key.
Yeah, so this wasn't a clinical failure. It was a data entry problem, right?
Well, partially data entry, but also partially, when you query your database, you only have so many options in your reports, right? They have canned reports. So you go into your intubation report and it just shows you all the supposed intubation attempts. But that data that it's giving you is highly dependent on how the providers entered the data in the first place. So we use, for examples, Kevin, stuff like, show me all my STEMIs. Okay, it's going to only show you a report that shows you calls where the provider called it a STEMI. But
hang on, Paul. You're talking about the reports you get, the generic reports you get off of the ePCR software, right?
Yeah, that's exactly what I'm talking about. So there are limitations, and it's not the PCR's fault. It is what it is, right? It's a data collection tool. It can't interpret that data for you. So if you do something like query it for saying, hey, I want to know if our STEMI identification rates are good. So you say, show me all my, my chest pains, and it shows you all your chest pains. And then you go and you look at the 12 leads and say, yeah, 100% accuracy. Every chest pain that was a STEMI, they called it and they called it in. But what about that little lady had nausea who should have gotten a 12 lead who could have been a STEMI, that because she didn't have chest pain, they didn't do an evaluation on. They didn't do a 12 lead on. That could be a missed opportunity, a missed STEMI that you won't even know about in that standardized canned report.
Yeah, and that's a big problem. Creates huge liability. In this case, it was OEMS, the regulatory folks at OEMS.
Right.
But, there's also potential for medical malpractice allegations.
Right.
All kinds of. I got a question for you. Why conventionally isn't this kind of, and this isn't, I wouldn't call this low-hanging fruit, a low-hanging fruit analysis. It's a medium-hanging fruit analysis. But why doesn't the medical director, why doesn't the chief, why doesn't the EMS CQI person, why doesn't anybody pick up on this, scratch their head and say, gee, this doesn't make sense? Why don't they, is it a not having enough tools in the toolkit problem, or
again, it's a variety of issues. First, you've got to understand that the data is faulty in your ePCR program. That should be your starting point, and most people don't. They think that everything is accurate and clear in the report when it may not be. So that's a mistake. And they beyond that, it gets compounded when providers put erroneous information. They factually don't get something right. So if they have a shortness of breath patient and the patient, and they call it CHF and treat it as such, but it really should have been bronchospasm that was treated, for example. Your report that says, show me all my CHFers is not going to be accurate, or show me all my respiratory patients who have bronchospasm. So if the medic gets something wrong, the software doesn't know that. And the whole point of CQI is to find that wrong stuff so that you can fix it. But the data that you're getting from the report may not indicate that there's a problem.
Yeah, and if nobody questions that, you end up punishing the medics for doing the right thing. And that creates, all kinds of problems, right? What's your experience with punishing the medics for doing the wrong thing?
Yeah, it happens all too often. We're not a punishing CQI process, right? We're an education, teach, coach, mentor type process. We don't actually do any sort of disciplinary action based off of our CQI programs. That's management and medical directors' jobs. But unfortunately, we see management and medical directors sometimes make decisions based off of that erroneous data, and they don't realize it's erroneous necessarily. So they haven't looked deeply enough to try to make sure that that data is accurate before they start instituting changes. And this is where it's kind of interesting, is that it's always going to happen to some degree, and you have to understand it. So when you're blaming people for stuff and then they don't get better, you blame it on the person, right? That person's not listening to what I'm telling him. He's going against what our wishes are. And they may not be. They think they're doing everything right in terms of their care and then how they're documenting it. And it could simply be garbage in, garbage out type of stuff. The provider may not even realize that what he's putting or she's putting in is garbage data. So yeah, it oftentimes leads to discipline, certainly leads to accusations that the staff is not doing everything they're supposed to be, and people get a little bit disgruntled when they hear over and over all the stuff that they're doing wrong, when a lot of them in their gut feel like, but we don't, I don't see where that's a problem. Why are we getting hammered on this when everybody I work with does a really good job on that, type of thing.
Me too. We know how to intubate.
Yeah.
We're doing it.
I can't remember the last time there was a bad tube, kind of thing.
Yeah, that's right.
So yeah.
All right. So why PCR software isn't PCR software telling the whole story?
Well, it's telling the story that it can tell. It can't tell if the patient is in a third-degree heart block and the provider puts that it's a sinus rhythm. Software can't tell it was really a third-degree heart block, so they're looking at that as a sinus rhythm.
Well, the software's failing us. Yeah,
well,
the software's failing us, isn't it?
It doesn't. Isn't it? No, not really. I mean, the software's intent is, hey, provider, put in what was your rhythm on this patient. Oh, it was a sinus rhythm. The software doesn't know the difference. It can't tell you that you got that wrong. So the software can only do so much. It's your CQI process that has to identify where those gaps are and then correct them, and how to find them, how to know where the likely gaps are, what types of things will lead to bad data, what can you do about it to try to fix it to the degree that you can. So it's really incumbent on everybody using the data to understand the data and understand the shortcomings of that data. Every report has a shortcoming to it. In a report that says, show me all my STEMIs, show me all my chest pains that were STEMIs, that report's not going to identify the missed STEMI that they didn't even take a 12 lead on, shoot a 12 lead on. So that's not the PCR's fault. It may be the provider didn't document well, or maybe didn't identify something they should have. There could be a variety of other causes. But ultimately, it's the CQI process that has to know that their data has shortcomings in that regard, and they have to have a backup plan for finding those that data that might be missing to make this a complete picture.
Would you say that this is true? Most PCR software is designed around compliance and not clinical reality?
Yeah, I think all of them have some degree of shortcomings. And again, it's not their fault. It's a complex piece of software that has to incorporate all sorts of different scenarios. Yeah. And one scenario you can't account for is just the provider putting in wrong data, right? Garbage in.
Right.
So
uses drop-down menus, check boxes, forced fields, miss one checkbox, and you're screwed.
Well, there was one PCR that we had that we were working with a long time ago not a long time ago, probably 2 or 3 years ago. And the drop-down list for patient complaints had dozens and dozens of patient complaints.
Yeah.
But they didn't have some other things. Like if the provider, for a short time for that agency, they didn't have sepsis as a complaint in their what's the patient's problem drop-down box. So they would, in their narrative, write, this is a sepsis patient, we identified it, we gave a sepsis alert, we treated it as sepsis, blah, 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 blah. But in the what's your clinical impression, it said something other than sepsis. So the auditor would read and go, wait a minute, it doesn't say the patient's in sepsis. They say altered mental. It says something else. And when you talk to the provider, say, well, that's the closest thing I could pick that I thought would be close enough to the condition I was treating. So it forced the providers to pick faulty data because they didn't have an option. And we see that with drop downs that have short drop down list options, and then they have an other category. From a data collection standpoint, that's a way to capture things that are unidentifiable in the rest of the list. But if that list is not very thorough and you're picking a lot of others, that becomes a grab bag of garbage data that, could be all sorts of things that could be in that other category. So again, you got to know that when you're generating your reports.
So we're creating distorted records that people are using, researchers, scientists, medical directors,
right.
policymakers.
Right.
And because of that distorted record, they're really flying blind.
Right.
I mean, they don't know what's going on.
Yeah. Well, there was a podcast by one of these big EMS data companies where they do it's like an add-on program that spits out more reports off of your ePCR program, and they've got all sorts of metrics and all sorts of reports, and that's all great. But I remember sitting and listening to the person who was representing that company say that the problem is this is so much garbage data that our reports are not all that accurate, and I was amazed that he even admitted that.
Unreal.
But it's a true statement, and you've got to mitigate that to the degree you can so that you're making proper decisions.
The whistleblower. I as a lawyer, I like whistleblowers.
Yeah.
All right. The narrative, Paul.
Yep.
Where everything gets explained that happened to the patient or didn't happen to the patient, that gets ignored in most of these baseline ePCR analytics. Is that accurate?
Well, the analytics, for the most part, have a hard time, and maybe this will change in the future with AI and stuff, but at the moment, there's a bit of a hard time for those ePCR programs to pull data from the narrative since it's free flow text. So if you put, and again, this is a problem we had here in Massachusetts a number of years ago, where there was people were putting a patient's blood sugar in the narrative and not putting it in the blood sugar field. So your NEMSIS data, your state data, everybody who extracts data from those PCRs looks to the blood glucose field to see if you took a blood sugar and what the number was. So again, one report showed a 50% compliance with patients who were diabetic, who had an altered mental status, who were not getting sugar. We're not getting a blood glucose done on them, and we're not getting a glucose. But then when you look at the data more closely, you find that a lot of those cases, the providers were putting the blood sugar numbers in their narratives, or put the treatment in the narratives and not in the skills and procedures section. And since the data, the reports can't read that data and extract it and put it into report form, it's just grossly inaccurate data. And providers put a ton of data in their narratives that they often don't include in the drop downs. In fact, a lot of folks tend to use the narrative for most of their stuff and don't use most of the drop down fields, in my experience, in a lot of agencies. A lot of medical directors now are getting to the point where they want us to flag calls as being improper documentation if they're not specifically using the right drop down field, so they can try to capture that data for NEMSIS and for management and reporting purposes.
Yeah. And leadership, Paul, they don't often read the narratives, right? I mean, they rely on structured data reports. They're busy people. They don't have time to get into the weeds. They want to rely on accurate, unbiased, structured data. And in the narrative, when you're relying on that structured data, you miss the nuances of the call, right?
Yeah, that's the whole point of this podcast, Kevin, is that if you're sitting in your Ivy Tower generating reports from ePCR to start your CQI process, you're already starting at a faulty point. You really need to read these reports, read the narratives, and do a secondary data collection attempt before you start spitting out reports. We don't use, when we do QA with clients, we don't use their ePCR reporting software at all. We built our own software, and we ask the questions that need to be asked to get to that data specifically. So in our software, for example, for a sepsis patient, it says, is this patient potentially septic? Yes or no? And did the providers do a sepsis assessment on the patient? And then we have other sepsis questions too. They give a sepsis alert and whatnot. But that creates a yes-no matrix, right? Should this patient have been looked at for potential sepsis? Yes or no? If the answer is yes, then did they actually do one? Yes or no? So when we generate a report, it says you had 10 patients who had assessment for sepsis or who were evaluated for sepsis. However, you had 15 total patients who should have had an assessment for sepsis. So 5 patients didn't go through the differential of potential sepsis because the providers possibly weren't thinking of it or whatever the issue is. Those are the misses. Those are the ones that you're not going to get from a standard report that you want to go investigate to see whether they were legit, if they were sepsis or not sepsis, and then add that data depending on those answers so that your data is more accurate and reflective of what's really going on.
So if the software fields say one thing and the narrative says another, generally the data wins, even if it's wrong.
Generally, it does. Yeah, and a lot of software packages, it looks to those fields and it just can't extract data very well from the narrative.
So we're forced using ePCR systems and what their analytical capabilities are, and it gets us to a point of we're relying on what's easy to analyze and what's not actually true.
Correct. Yeah. Think of the implications of that. Think of the implications of that.
Dangerous.
Absolutely.
Right?
And this is on a national level as well as a state level, because every state they have to collect the NEMSIS data from the providers, right? They upload it to the state agency, and then that data gets sent to NEMSIS. And all these people are making decisions off it. Then your medical directors are using ePCR data to make medical director decisions, and your management teams using that same data. We have one agency where the dispatchers handwrite dispatch times, and they're busy answering phone calls, dispatching multiple units and that sort of thing. The crew goes out. The crew's data shows that they started treating the patient 3 minutes before they arrived on scene. Well, how's that possible? Unless you're a damn good EMS system that you're providing patient care before you get dispatched. How does that happen? And it starts with bad dispatch data and bad times. And I can't tell you how often this, we read a report that says, how come it took you 6 minutes to defibrillate that patient? It didn't. As soon as we got there, we zapped them. And then you find out that dispatch times don't correlate to the rest of their times. Their monitor times don't match. And it's appearing like there's bad patient care going on when, in fact, there may not be. So try collecting that data or making changes based on faulty time data.
Well, try being a paramedic in a high-profile, nationally televised murder trial, and you're answering questions based on garbage in, garbage out, and you're looking like a complete bobo, and making your medical director look like a complete bobo.
Yeah, the whole system looks messed up.
Yeah. It is. It's dangerous. We're building policies, making hiring decisions, disciplining people based on bad or incomplete information.
Right.
This is a living EMS version of a Dilbert cartoon strip.
Oh yeah. We love Dilbert, right? We watched that for years.
I mean,
and this is exactly the business equivalent, the EMS equivalent of a business Dilbert situation.
Absolutely.
Well, the data says.
Yeah. All right. EMS CQI or EMS continuous quality illusion. In the garbage in, garbage out article that can be found at www.gerardassociates.com, you introduced a great term, continuous quality illusion. What do you mean by that?
I mean that if you're using this erroneous data to start your CQI process, you're looking at illusory data that will lead you down the wrong path of improvement. You just can't apply the proper fix if you can't diagnose the problem accurately to begin with. Yeah. So it's an illusion, the data that you're getting from and there are so many examples of the data being wrong. It's not just if you corrected a couple of things, everything would be okay. There's all sorts of ways that your data can go wrong before it ever gets into your ePCR program to be produced for data, to be used in the CQI process or management process. So it's an illusion. You need to clear the cobwebs from your eyes. You need to look at the data properly. You need to understand the weaknesses of the data, and you need to take steps to mitigate those weaknesses so your data is accurate before you start taking actions on how you're going to improve things.
Yeah, it's Dilbert, chasing phantom trends based on faulty data, fixing problems based on faulty data that don't exist, and ignoring the ones that do. So even with the best intentions, CQI can become punitive based on data hallucinations, right?
Yeah, it can, especially if you've got that punitive approach. Everybody you talk to in EMS CQI says, oh, no, we're education-based. But the reality is that there's a punitive, at least it feels punitive to the providers. And there is nothing worse than having to deal with these difficult problems with providers, and you're going to get pushback from them. But if you know your data might not even be accurate to begin with, that gets really sketchy. You really this is a major problem on a national scale that needs to be fixed.
That's why we're sounding the alarm. That's why we are waving waving the yellow caution
Right,
flag on
right,
this stuff
right.
because folks aren't talking about it. Everybody's pie in the sky. Their jobs are going to become easier. They can leave their heads at home and just pump everything into Chat GPT. And that's where it's going.
Well, worse than that, there's you have decision makers making decision on this. How often do you read on any of the news wires that this agency collected data on XYZ topic, and everybody's assuming that the data is accurate. But I got to tell you that in most cases, my suspicious mind goes to I'd like to see how they're collecting that and see where the weaknesses in their data collection is, and see if the results would be the same if those problems with their data collection were corrected. Would the results still hold? And in a lot of cases, I know it won't because the data is just grossly inaccurate.
Yeah. You got to get into the mud and you got to get down to the roots.
Correct.
And you got to do that. It's being punitive versus just culture. And you end up punishing good providers, misdirecting training efforts.
Mm-hmm.
I mean, creating monstrous credibility problems between labor and leadership.
Right.
And it's about checking boxes, producing reports rather than improving patient care.
Right.
And as you and I both, I mean, we go back a long time in EMS, and if medics feel like they're being graded unfairly, they disengage.
Correct.
Nothing worse than this inter-office bias politics stuff.
Right.
How you lose trust, right?
Absolutely. And or they push back much harder. They know they feel they're being unfairly, unjustly accused. And so instead of them working with you to try to figure out what happened and fix it, they have more of a defensive posture because they know there's a good chance they might win because they just can't see what management's seeing in that data.
Hey, if you're out there and you feel like you're being disrespected by EMS CQI, you may have an emotional distress claim. So, contact a lawyer. But yeah, it's we got to up the game. Losing trust from a staff with all these EMS shortage issues going on, not going to help.
Right.
So fixing the problem, coaching, not condemning. We've diagnosed the problem, bad data, bad assumptions, bad outcomes, Paul. So what is the fix?
So the first thing people should do is they really should spend a lot of time on documentation with providers. And I'm not talking about running another class on patient refusal documentation. Everybody's had that a million times. You sit in the back of the room and you scroll your phone or you take a nap. The reality is that people tend to think when you run those generic courses, they think that you're talking about other people. I do a pretty good job with documentation. It's meant for other people. I don't need to pay attention to this. Or I've heard it so often, and I feel confident that it's not me, but it could be you. So getting providers, giving them individualized feedback on how well they document reports and what types of things they are missing in their reports to make a complete and accurate report is paramount. You got to get down to the nitty gritty, into the weeds, like you said, and give individual providers individual feedback. I've told a story before on our podcast, Kevin. Back when I was a rookie paramedic back in '86, my manager came to me and said, "Hey, Paul, your documentation sucks." And we were doing those handwritten triplicate,
the SARFs.
The SARFs, yeah, exactly.
Yeah.
And I was like, no way, man. I read everybody else's reports and I'm doing much better than everybody else. And he's like, nope, you suck. And we went back and forth. And it wasn't until he took a bunch of my reports and highlighted them in red, all the missing stuff on my report, and showed it to me, that it became real to me. Because in my mind, I legitimately thought I was doing a pretty good job getting most stuff in terms of my documentation, and clearly I wasn't. So until you get to that level of feedback where a provider knows where he or she needs to improve upon, you're not going to get there. So that's number one. Number two is getting people to use the drop-down boxes and all those elements so that the reporting is at least a little bit more accurate. So that's a big thing. But the one that I think is the harder thing to fix is erroneous data put in by providers, either because they just made a mistake in data entry or, more importantly, they just misdiagnosed what's going on or mistreated what's going on.
Yeah.
That's your CQI process. And for us, we do a couple of different things. One is we have our scoring system, which overlaps the data reports. So we have all those data reports like everybody else does, but we also use our scoring system. So in that cardiac arrest airway management thing, for example, their cardiac arrest management was 95 point something % compliance. They were doing really, really well on their overall management. If they were missing tubes, missing a lot of tubes and not doing a good job with airway, that score would have been a lot lower because we would have graded them at a higher infraction level, for example. So we basically have the scoring, which is an overlap to the data to see if they match. If we're scoring really well and your data reports are showing something wrong, then you got to go and find out what's wrong with the data. If the data is really good and they're scoring poorly, then it's because what people are doing is what they're doing. You got to fix it from a CQI perspective. So we have that overlap scoring system that we also report out on simultaneously to having those secondary reports. The other thing we do when we audit reports is we created our database, as I mentioned to you, Kevin, where our auditors are asking stuff like, is this potentially a stroke? Did they at least assess that patient for potential stroke so that we can capture not only the ones where the providers saw it was a stroke and they accurately identified it, but we can see where they didn't do a differential on that patient to consider stroke for somebody who has stroke-like symptoms. So those are the ones your PCRs are not going to find because it's going to be labeled as an unconscious patient or some other thing that if they treated the unconsciousness, you think, oh, everything went great. But if they missed a stroke and that's why they're unconscious, then it didn't go great. So they can meet protocol on the unconscious stuff and completely miss the point on what's wrong with the patient, and your report's never going to show you that. So we actually, in our CQI process, when auditing a run report, we actually look for those discrepancies and we put them into our database so that we can find the missed stuff that your PCR just can't show you. So you got to come up with a system such as that in-house that'll help you to identify some of these issues.
And I don't think that there is a better system than the G&A way, although I'm fairly biased with that. You know, and it starts with people. We need to coach our medics, not just audit them. Teach them the why of documentation.
Correct.
Explain how their narratives protect them, the patient, and their agency.
Right.
And we got to create a just culture where people aren't afraid of making honest mistakes and reporting these mistakes. Mm-hmm. Right?
Yeah, people are be honest. Yeah.
So instead of gotcha QA, we lead with teaching, coaching, mentoring, and compassion. Right, Paul?
That's absolutely true. One of the hallmarks of CQI is that CQI shouldn't be about blaming people. It should be about finding problems with the system and fixing the system. This is an area where people get blamed for a lot of bad clinical care stuff or documentation stuff when it's really a systems issue. So the system needs to be fixed in terms of how you collect QA, how you report QA, and how you interpret those reports and know where those reports have shortcomings so you can go find the right answers, as opposed to just pointing a finger at the provider and saying bad EMT, bad paramedic, fix it or you're fired.
Yeah, you'll learn more in a 5-minute conversation with a paramedic than in reading 50 or 100 shots, right?
Oh, absolutely. Whenever we talk to providers and we say, hey, how come you're not documenting whatever the way it's supposed to be documented? They'll tell you there's no drop-down field for that. I can't do it, and they'll, and you got to take it serious, right? You got to go back and find that and fix that problem and not just keep blaming the provider. But unless you talk to the provider, you're not going to hear that. And most people, again, sit in the Ivy Tower, spit out reports, and then try to manage the reports, right? We got this out. We set up a class. So we ran a class because our data said our refusal documentation sucks. So they run the class, but we've all had those classes so many times. The reason your refusal documentation still sucks is because nobody's giving individualized feedback and action items that the individual can do to fix his or her reports as opposed to using the global strategy. So this doesn't require a shotgun approach because everybody knows to avoid the shotgun approach. This is more of a surgical, we need to talk, you and I, about your documentation on patient refusals and where you can improve them, Kevin. So until you get to that level of specificity, you can run as many documentation courses as you want. You're probably not going to see a lot of improvement.
Yeah. That's the G&A way, right?
When
is. Medics feel respected and heard, they write better charts.
Bingo.
And when they write better charts, the charts reflect reality. That leaders can finally make smart decisions. That's the path forward, no?
That is the path forward. That's a great way to sum it up.
All right, so final thoughts and takeaways. We've covered a lot today, Paul. If you had to boil it all down, what's one message EMS leaders and CQI teams need to hear about the use of NEMSIS data?
Don't trust it unless you've verified it. And I'm talking about not just the stuff that's in the reports, but the stuff that's not in the reports that should be. So just don't fully trust that, especially to make your management decisions until you've done a thorough investigation of the data.
Yeah, you got to get out of those spreadsheets and into your stations, talk to your medics, read their narratives, ask them why, ask more, listen more, improve smarter. Is that a good G&A way message, Paul?
That's it. That's the way to close out the show, Kevin.
All right. Thank you, Paul. Well, articulated EMS CQ advice as always, and you look pretty good doing it. So this wraps up our nemesis garbage in, garbage out episode of the G&A Way EMS CQI podcast. To learn more about EMS CQI, the G&A Way, and the services we offer, visit our website at www.gerardassociates.com for the latest articles, tools, and how to access our national EMS CQI consulting support. How cool is that? You're not alone. We got your back. Be sure to subscribe to Podbean, Apple Podcasts, YouTube. You'll never miss an episode. Please leave comments. We like the interaction. For Paul Gerard, I am Kevin Kelly. Stay safe, stay in the fight, and Godspeed.
Stay safe, folks.
On fire.